Neurology. All right, guys. Real quick review of the nervous system. As you can imagine, this is pretty complex. The nervous system involves a lot of moving parts, and it's basically the control center for everything that's happening within inside of you. Now, the brain, or this nervous system, is made up of the central nervous system. Well, the brain is made up of 4 regions. The cerebrum is the largest portion of the brain. Think of it as the gray matter. The diencephalon is the thalamus and the hypothalamus. It also includes the pituitary gland. The cerebellum is this big section in the back. It helps regulate motor movement and bipedal movement. And then finally, the brain stem, which is made up of 3 parts, the medulla, pons, and the midbrain. This is the one I want you guys to focus on as far as EMS. This is also where all of the main functions of our brain are controlled. I'm sure you guys have heard the phrase, the lizard brain. This is what we're referring to, the brain stem. So here's an example. You can remove all of the brain except for the brain stem, and the person will still live. They won't be conscious. They'll be in a coma for the rest of their lives. In fact, most people in comas, their brains have completely rotted away, and the only thing that's functioning is their brain stem. This keeps your heart beating. This keeps your blood pressure in check, keeps you breathing, all those important things, okay? Keeps your GI, you're moving food and extracting nutrients. All the things that we need to live, but we don't have direct control over. Those are all controlled within the brain stem. In fact, it can't really happen to humans because humans basically need their brains. I mean, humans that are still alive and walking around are still alive with their brains rotted away are in comas. But some animals, they don't really need much of their brain to act. In fact, most animals are dumb. Like, I hate to say it, your dogs are dumb, your cats are dumb, your chickens are dumb. In fact, there's a really amazing case of a chicken that lived for about 15 years after it had its head cut off. Yeah, no, that's a true story. You guys have maybe seen or heard about chickens being beheaded, and what happens to them afterwards? Well, they run around in circles. Their bodies continue to act. So a farmer tried to cut his chicken's head off, but he didn't cut deep enough, and he left the lizard brain portion of the chicken's brain. Now, basically, the chicken was still able to run around. It was still able to eat through a little hole, and it had to be fed, but this chicken was running around without a head for, maybe it wasn't 15 years, but it was multiple years without its brain. Brains are not as important to animals as they are to us. Now, obviously, for animals like cats and dogs and elephants and wolves and bears and things like that, more complex mammals, this is a different consideration. A chicken is not the same. A chicken is a bird. They're dumb as hell. All right. I'm sorry if you guys love birds. I love birds too, but they're dumb as hell. They don't need that much of their brain to activate. All right. I'm going to show you guys a better picture of the brain. We can go over this stuff. The brain stem, though, is the most important stuff. The medulla is the lowest part of that, and the medulla is what controls the basic vital functions: cardiac, respiratory, vasomotor centers. It regulates your autonomic nervous system. Remember, that's like the system that you don't really have control over, just happens on its own, as well as involuntary functions like your heart rate, respiratory rate going up and down, your vasculature constricting or dilating, and also vomiting. That's also controlled in here. That's why people that are in comas have gag reflexes, because that's controlled in your medulla. This is the brain stem, this orange section right here. Again, the pons is the upper section right here. By the way, this is the diencephalon, this kind of brown section, including the pineal glands. I think that's, or the pituitary gland. This is the pons, medulla, and the spinal cord going down there, as well as the midbrain up above the pons. This is the cerebellum, that section in the back. So again, the medulla right there is what's going to regulate most of these important functions. Now, why is that important? Because the medulla is what's closest to the foramen magnum. Remember, the foramen magnum is that hole in the base of the skull that your brain protrudes out of. So if your brain starts increasing, intracerebral pressure increases within the brain, there's nowhere for that brain to go except for, boom, herniating outside of that hole. So the first thing that's going to be pushed up into that foramen magnum is your medulla. That's why we see effects called Cushing's triad. The medulla is now herniating into the brain, So we're going to see respiratory changes, right? That's one of the triad is irregular respirations. Remember, respirations are controlled in here. Bradycardia, remember, heart rate is controlled in here, and a widening of the pulse pressures. Your blood pressure vasoregulation is controlled in here too. So essentially what we're going to see is our systolic number going up. The pressures are going to get further apart. That's because this is literally being pressed. So that's why that's important. All of your most important features are housed in there. We're going to go over, when we talk about the endocrine system, we're going to go over the hypothalamus, the thalamus, and the pituitary gland more later. Those are all part of something called the Diencephalon. That's not important that you know that. Just know that the Diencephalon also controls a bunch of other things related to risk and rewards. In other words, if you're afraid of heights and you're very cautious around cliffs, that's because when you're around heights, your amygdala is going crazy. I don't think I have a picture of the amygdala here. Oh, here we go. There's your amygdala. These little structures, they're going crazy. I really recommend you guys check out, if you guys have your Disney Plus accounts, you're all done watching The Mandalorian, you should go check out a really cool documentary called Free Solo. It's done about this climber called Alex Honnold, who is a free solo climber. What does that mean? It means he climbs mountains without any ropes at all. If he falls, he dies. He is absolutely amazing. But it's clear from watching the show that he's not your average person. It almost looks like he's on the spectrum, Asperger's spectrum, because he has a very flat affect. He doesn't really react to things in one way or the other. He doesn't get sad. He doesn't get happy. He doesn't cry. He doesn't laugh, really. He barely does any of those things. They do a brain scan of him at one point during the show, and they discover that his amygdala has almost no response. The amygdala is where we process risk and we get rewarded for doing things that are pleasurable. His has less of an effect. So what does that mean? It means that he needs huge stimuluses in order for him to feel happy or sad. It takes a lot. Probably, I bet we would discover that most people that are on these spectrums have different effects in their diencephalons. So that's also why he's able to climb mountains and not really get scared, is because although it's scary to climb a mountain, be 3,000 feet up at the edge of a cliff with no rope. And by the way, it's insane what he does. Absolutely insane. There's no amount of money you could pay me to do that. I mean, I couldn't climb it with a rope, so it doesn't matter, but even so. So it's kind of an amazing thing, just shows you how much we're still discovering about how the brain works. Kind of a cool story. The thalamus and the hypothalamus, I'm going to talk more about those. The thalamus essentially just sends signals to the hypothalamus. So the thalamus goes into the hypothalamus, and that goes into the pituitary gland. We'll talk about those again when we're talking about the endocrine system. Essentially, the thalamus just transmits messages from the brain into the pituitary gland, so you can have hormone releases. The cerebellum is that big structure in the back under the occipital lobe. I don't know if you can see it from this picture. There it is. Gray matter composes the outer layer, white matter in the inner. Don't worry about that. It helps managing normal, precise movements, the ability to maintain equilibrium, and helps to sustain normal posture. This elevated hugely once we became bipedal creatures. This also helps us do things like walk and any activity at the same time. Walk and chew gum, right? We always make jokes. I bet you can't even walk and chew gum at the same time. Yeah, well, most of us can. And this is why. Most of us don't even really have to think about walking, even though it's actually a pretty complex thing. Maintaining balance involves the use of many, many, many muscles contracting all the time, right? Those fast twitch balancing muscles. Think about balancing on one foot. That's actually physiologically a pretty amazing feat, but one that we don't have to think very much about because it's all handled in our cerebellum. Think about walking, chewing gum, and then opening a Snickers bar at the same time. That's a lot of action going on that we don't have to really care too much about. Some studies have shown the cerebellum may have multiple functions, not fully understood. You don't say. Helps us in overall coordination. Finally, the cerebrum. This is the biggest portion of the brain. This is the gray matter. This is the brain matter that we would think of. It's separated into a right and left hemisphere. This is a really important feature of our brain. When we talk about birth defects, one of them that happens is when the brain fails to form into two hemispheres. Spoiler alert, you're not going to live if that happens. This is a very unique feature in mammals, this dual hemisphere brain. We don't really know why it exists. There's a lot of discussion about the right brain being the creative side of the brain and the left side being the more logistical side of the brain or logical side of the brain, but that's not necessarily true because most features are on both sides of our brains, right? Like if we are understanding language, that's on both sides of our brain. But there is one interesting distinction, which is that on one side of our brain, on the left, we think more about the individual words that are being said. And on the right, we're picking up on things like intonation and emphasis. If I think about this, there's a really famous example in the English language. I can say the sentence, I never said she stole my money. Now, depending on where I put the emphasis, I can form many different sentences. I never said she stole my money. 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 I never said she stole my money, or I never said she stole my money. Those are 7 very different sentences. Do you guys hear what I'm saying? You guys are all picking that up on the right side of your brain, not the left side. The left side just heard the same 7 words or whatever it was over and over and over and over and over again. Your right side is what picked up on my intonation and my emphasis. It's also what helps pick up on things like sarcasm. So are the 2 hemispheres of the brain related? Absolutely. Do they fulfill different functions? Unclear. One thing that we do know is that they play a role in handedness, which is why most of us are right-handed. Some people are left-handed. Why? Excellent question. I'll get back to you on that. The lobes of the brain are named for the overlying bone structures: parietal, occipital, frontal, and temporal. I'll give you guys kind of an easy overview of them. Don't worry too much about what they all do. It's not really going to be tested on. Here's what makes it easy. Occipital, vision. All right. You hit the back of your head, you'll see a big pop of light. Don't do it, but if you've ever done that, you know what I'm talking about. The frontal lobe has to do with our personality, our decision-making process. It's what essentially makes you, you, and me, me. The rest of these are all pretty similar for all of us. This is what really changes in person to person that makes us unique. The temporal lobe, think of it, it's closer to the temples, so you can remember it that way. It's also going to be largely in charge of speech, language, sound, understanding those things, right? If we hear a noise, we can tell whether it's a bird singing or a gunshot really quickly, right? Because our brain is programmed to understand the differences between those stimuli. And our parietal lobe, as far as we understand, it helps us also with movement, very precise movements. Think about running. Think about a football wide receiver running, looking over his shoulder, and then catching something, tracking it with his eyes, following it over his shoulder, catching it in his hands, all while maintaining maximum running speed. That's actually pretty impressive. Let me give you guys another example. You're sitting down on your sofa and you're opening up your Snickers or your Reese's peanut butter cup and you're not crushing it. That's something that takes a lot of precise movement. It takes strength and precision and dexterity, but it also takes a soft, gentle touch. So you're not squishing your Reese's peanut butter cup. All of these actions, whether you're getting paid millions of dollars to catch a football or paying for a Reese's peanut butter cup, are involving multiple aspects of your brain to fulfill these functions. So again, frontal, personality; parietal, spatial orientation. Where are we in the universe? This is why if you're standing far away from me, I have a tennis ball, I can throw it to you. And if I'm fairly athletic, I can get it pretty much right to you on my first throw. I don't need to think, okay, he's 30 feet away, so I need to throw it with 18 miles an hour of my hand move. You don't have to think about any of that stuff. It's automatic. It's all controlled in your parietal lobe and the cerebellum. All right. Moving on down, the spinal cord. It lies within the spinal canal, which is the hole that runs in between all of your vertebrae. It's attached to the medulla at the foramen magnum, like we were talking about. It's about 17 or 18 inches long. It's kind of shaped like an H, as you can see. There's gray matter on the inside and white matter on the outside. don't worry so much about the difference between gray and white matter, because realistically, we don't really know the difference between them either. We just know that those are two different formations of neural tissues. Spinal cord forms during the 4th week of pregnancy. It's one of the first things to form. It's formed when the neural tube, the precursor to CNS, begins to close up. So it's kind of an interesting thing, and we'll go over this, I think, right now. Yes. So the neural tube is one of the first things to form. And this kind of helps give the blueprint of everything that's going to form afterwards. By the way, kind of interesting distinction. We've always learned that the central nervous system is the brain and spinal cord, but there's actually one more thing that's actually part of your central nervous system. And it's your adrenal medulla. Your adrenal glands sit on top of your kidneys. Your adrenal glands are made up of two things, the adrenal medulla and the adrenal cortex on the outside. The adrenal medulla is actually CNS tissue. That's right, it's neural tissue. Your interplay between the adrenal glands, your kidneys, and your CNS is very intricate. Keep in mind, your kidneys are actually attached to your spine, okay? They're attached almost directly to the CNS. The part of the kidneys is actually part of the CNS. It's kind of a common misnomer that we always think it's just the brain and the spinal cord, and also the adrenal medulla, which just makes everything weird. Your kidneys, by the way, are very special. I'm going to get more into this tomorrow when I talk about them, but holy moly, you guys should be absolutely amazed at the kidneys. We tend to group them in with all the other abdominal organs, but no. The kidneys are very special. The kidneys are very amazing. The kidneys are quite extraordinary. And the adrenal cortex that sits on top of them is just part of them. So what happens when the central nervous system fails to form up correctly? We can get this condition called meningocele. This is a type of spina bifida. It'll depend how much is appearing here. Meningocele, we're looking at the meninges. So the meninges protect the brain and the CNS. Or sorry, they protect the brain and the spinal cord. We know that we have our skull and we have our vertebrae that protect it, but we also have 3 layers of the meninges to protect it. They are named the dura mater, the hard mother in Latin. That's the outside. Then there's the arachnoid space, which is a CSF, and it kind of looks like webs. That's why we call it arachnoid, not because there's spiders living in you. Although that has always really bothered me. Why the hell did they call it arachnoid? Why not just call it the web structures? Whatever. And then finally, on the inside, we have the pia mater, or the soft mother, and that's what sits right up next to the CNS. This can malform during pregnancy in the neural tubes. So this is the meninges are sticking out there. And we'll talk more about those when we talk about birth defects on day 3. So we have, like I said, 3 layers to protect us. The dura mater on the outside, the pia mater, and then the arachnoid space, web-like, filled with cerebrospinal fluid, which acts as lubricant and as a, almost like a bumper or like a shock absorber. CSF is also in the ventricles of the brain. What do we mean by ventricles in the brain? The word ventricle does not have to do with the heart, despite what you might think. Ventricle just refers to a structure that is hollow that can fill with liquid. So remember how I told you that everything in your body is kind of like a soaking wet, sopping sponge, like your kidneys and your liver and your brain, all that. Your heart obviously it does have an opening in it, right? It's got a big hole in it so it can fill with blood. Your ventricles in your brain are the same way. They can fill with the cerebrospinal fluid. And this is also what cleans and processes and filters the cerebrospinal fluid. Here's a picture of what they look like within your brain. Remember we talked about the endoplasmic reticulum as a way of shuttling things around within the cells? And then the sarcoplasmic reticulum is a way of shuttling things around within the muscles. This is kind of a way of shuttling around CSF within the brain. All right, this is the last thing we're going to talk about today, guys. We're just going to go over a little bit of pathology of the CNS. Remember, pathology is the study of pathogens. In other words, how do diseases affect our CNS? Everything from headaches to strokes. Oops. Let's start off with the worst of those. Let's start off with strokes. So you guys are familiar with strokes, I'm sure. There are two main types of strokes we can have here: ischemic and hemorrhagic. Ischemic, as the name implies, means that we have a reduction in oxygen flow to some area of the brain. This accounts for most strokes, about 80 to 85%. Blockage of a cerebral artery. Some of them are caused by thrombosis or a buildup of things over time, atherosclerosis. Remember, that's the buildup of thickening of the walls with plaque. Sometimes they're caused by an embolism or something flowing to that area, like a deep vein thrombosis. Now, bleeds take up the minority of them, about the other 10 to 15%, but bleeds have much higher mortality and morbidity rates. Now, you guys know that we give aspirin for heart attacks because it's a platelet deaggregator. If there's some sort of thrombus or embolism, that can help break it up. But we don't give aspirin for strokes because there's always a chance that they're having a hemorrhagic stroke, in which case aspirin would actually make the bleeding worse. It would probably make sense for most strokes for us to give aspirin. However, since we cannot differentiate the type of stroke in the field, we will never give aspirin to strokes. Again, thrombus means that it builds up over time, but eventually it becomes an acute blockage, right? And that's when they have the stroke. This is about 60% of all ischemic strokes. So most are going to be like this. These are stationary clots. Embolisms, again, remember they're traveling clots. Pulmonary embolism, you're sending a clot up to the pulmonary circuit and it's getting lodged in there and causing breathing problems. I had a patient that had an embolic stroke because he cracked his own neck. This scared the crap out of me because I used to crack my neck. He cracked his neck and he had had a blockage and it formed a clot. And when he cracked his neck, the blockage corrected and the stroke went up to his brain. This guy was 31 years old. Massive, massive embolic stroke. One of the scariest things I've seen because I cracked my own neck and now I don't anymore. Or I should say I do it less. I go to a chiropractor. Now, TIA, kind of like the angina of the stroke world. That's a good way to think of it. It's a mini stroke, but it's highly predictive of impending strokes. We used to think that they cause no damage. They do actually cause some damage. I mean, how could it not? Most TIAs last longer than 5 minutes, which is when neurological brain damage occurs. It'll usually resolve within 1 to 3 days. And there won't be very many signs that it happened. However, it did happen, and there will be signs. And the chance that this is going to cause a stroke in the future is high, because clearly we have all the signs and symptoms ready to cause a stroke. This patient will probably be placed on blood thinners immediately. Hypoperfusion strokes, when the brain's not getting enough perfusion. That makes sense. Trauma, illness, sepsis, all of these can cause hypoperfusion. And hemorrhagic strokes. Again, they're rare, 10 to 15%, very high mortality rates. I've seen a handful of these. They present very abruptly, very severe headaches, severe drops in their neurological abilities. The chance they're going to recover from this is unfortunately very, very slim. And intracerebral strokes, a rupture of a cerebral vessel. This is another type of hemorrhagic stroke. Usually caused by AV malformations, arteriovenous malformations. This is where the arteries meet with veins in these big groupings. This can happen if our brain doesn't formate right, or it doesn't form in the correct way. Look at this amazing push from this hemorrhagic stroke right here. This was probably taken post-mortem, if I had to guess. I don't expect that this patient would have survived that. Here's the thing about strokes, you guys, and here's what's important for you guys to remember about them. This pressure in the brain is what causes the damage, all right? And the same thing happens when we talk about traumatic head injuries, or that thing that affects football players, chronic traumatic encephalopathy. It's not so much the insult that causes the damage. It's the swelling that causes damage long-term. That's what causes these personality changes. That's what causes all the problems associated with head trauma over a period of time. It's pressure within the brain that kills us, not necessarily getting hit. There's aneurysms. Again, aneurysms is the same thing as in your abdominal aneurysms. It's just there's pressure building up and it starts ballooning out, and this is eventually going to rip. So the bleeding in the brain causes an expanding mass that compresses brain tissue. Rising ICP causes a secondary injury due to ischemia. In many cases, bleeding is too extensive or too rapid to prevent damage. This is why hemorrhagic strokes are so deadly. All right, on to seizures. Seizures are in a massive electrical discharge within the brain. Very few people actually have seizure disorders, 0.5%, but we're going to run on them pretty frequently in EMS. There are two types of seizures. There are primary seizures and secondary seizures. Primary means they're caused by a disease process like epilepsy. Secondary seizures mean that they're caused by something else, either getting hit in the head. I've seen lots of kids skateboarding without helmets that have seizures, fall and they hit their head and then they have a seizure. Or more likely, drug, alcohol abuse. Yeah, and it happens quite frequently. A couple main types of seizures. Grand mal are the big tonic-clonic seizures. These are the most common and the most easily identifiable. They're going to have possibly an aura, which is something that they sense beforehand, although they won't always remember this. Then they'll have the tonic activity, and then that's going to turn into tonic-clonic. Tonic means flexing the muscles, and clonic means flexing and unflexing really rapidly. That's what we think of as the shaking muscle fasciculations. Someone said that word earlier. Also going to be definitely a loss of consciousness during this time, probably a avoidance of their ureters. They might pee themselves, they might poop themselves. And then they're going to enter something called a postictal state. They're going to be very altered in here, and that's expected. So there might be a question on the quiz where they say, you just had a patient that has seizure. Which of these presentations is the most concern to you? And there will be two answers that you can eliminate. And then there will be two other answers that you have to guess between. And one will say he's altered, and one will say he has a laceration on his forehead. Now, in most cases, being altered is definitely more concern, right? But if we're going to a postictal patient, we expect him to be altered. That's expected. The laceration on the forehead is of more concern because now we don't know if he's altered because he's postictal or he's altered because he's suffered a traumatic brain injury. They're common. They are associated with significant morbidity and mortality. I would not say significant. I would say that there is a case called SUDEP, which stands for sudden unexplained death from epileptic seizures, or maybe it's not epilepsy. Sudden unexpected death from epilepsy. It's called SUDEP or SUDES or something like that. It's rare, but what's happening? So when we're doing these fasciculations, we're burning up ATP. We're burning up our oxygen reserves in our muscles. And most importantly, we're not controlling our muscles, meaning we're also not controlling our diaphragm or any of the muscles we use for respiration. This can lead to hypoxia at the cellular level. This can lead to brain damage. That's the big risk associated with this, not necessarily the seizing. Also, we can have petit mal, brief alterations, or partial seizures. These are one side or the other, no loss of consciousness, no postictal states. Very rare that you'll see these. I've seen petit mal and absence seizures. I've seen mostly grand mal seizures. There's also these ones called pseudo or hysterical seizures. This is also, another word for this is fake seizures. I hate that we have these slides in here like it's a real thing. It's not. I've seen a lot of fake seizures in my day. I can recognize them almost instantaneously. And hopefully you guys are good at it too. All right. Sometimes patients, when they enter postictal phase, they might have hemiparesis, the same as if they're having a stroke, facial droop, hemiparesis, unilateral weakness. That's because sometimes these seizures can affect one hemisphere or the other. Most hemispheres, or most seizures affect both hemispheres of the brain simultaneously, except for the partial seizures, which can affect one side or the other, and they can sometimes present like strokes. Finally, there's status epilepticus. This is when we have long seizures over 5 minutes, or we have multiple seizures with no period of lucidity in between. So like they start maybe like not even coming back around to being postictal, and then they start seizing up again. The risk of this is metabolic acidosis, which can cause fatal dysrhythmias. The same thing, right? Their muscles are all working very hard during a seizure. They're burning up their oxygenation. They're entering anaerobic exercise. They're becoming acidic. That can affect the heart. That's the big risk with seizures. All right. Myoclonus. You guys maybe have heard about myoclonic jerks. Myoclonus is a condition where we have sudden involuntary jerking of muscle groups. Sometimes it'll happen over and over and over again. It's rare, but it can happen. We consider those a type of seizure. Also, let's go down to headaches. Very rarely we're going to see headaches presented in the field. However, sudden onset headaches are of significant concern to EMS providers. Most headaches are what's called tension headaches. They're caused by muscle contractions in the face, neck, and scalp. It causes imbalances, it causes pain, and then this can cause headaches. Lots of things can cause headaches. We don't fully understand the pathophysiology behind headaches. Most headaches are benign and they go away after a few hours if you take some ibuprofen or some sort of other anti-steroidal inflammatory or non-steroidal inflammatory. There's also sinus headaches caused by allergies or irritation of the sinuses, and migraines, which are the most painful of them. I've only had one migraine in my life, and I do not recommend them. That was zero fun. One of the most painful experiences I've ever had. I've always had headaches. I've had a lot of headaches. When I was younger, I used to have them more. I only ever had one migraine, and I don't wish that on my worst enemies. Finally, we can have cluster headaches, which kind of come and go in bursts, probably caused by release of histamine. Remember, histamine makes all your vasculature more leaky so that the red and white blood cells can get out and start healing. Unfortunately, this can also create some cerebral pressure, which can cause some pain. How do we treat them? Usually we don't treat them with anything. Maybe a nasal cannula at a couple liters, maybe an ice pack over the eyes, turning the lights down, driving them in nice and slow to the hospital, or giving them Uber's number. Finally, let's look at, or not finally, but next let's look at delirium and dementia. Delirium is an acute state and it'll go away. Dementia is a chronic, comes about slowly, and it's there to stay, unfortunately. Delirium we'll typically see with someone acting crazy all of a sudden. Sometimes we call that excited delirium, usually related to drug and psychiatric imbalances. Finally, this will be the last thing we'll cover today, and then we'll be finished. Encephalopathies. Encephalopathies have to do with pathogens, pathes, in the encephalus, the head of the brain. Syndromes that cause progressive neuronal degeneration and brain dysfunction. Many causes, both organic and inorganic. We're going to look at a couple of them. AIDS encephalopathy is one of the big ones that kills people. We don't really understand how it's linked to AIDS, but HIV-infected macrophages can migrate to brain tissue. The virus can spread to neuronal cells, causing brain degeneration. Can also be related to TB, meningitis, encephalitis, lymphoma, toxoplasmosis. Don't get AIDS. Don't get HIV. It's not good for you. Here's some good news. We've cured 2 people with that HIV prior to COVID taking over the news and dominating it. We actually cured entirely 2 people from HIV. That's really good news moving forward. Potentially, we could have a cure in the future. By the way, what differentiates AIDS from HIV? Their T cell count. T cells are white blood cells that mature in the thymus. We also have B cells. They mature in the bone, and then some mature in the thymus. Those are called T cells. By the way, all of us, our thymuses are degraded, and they're not even really there anymore. So all the T cells we'll ever have. The problem is if our body starts attacking those T cells when we get HIV, then we lose our ability to fight off diseases. And we die to opportunistic infections. So the difference between HIV and AIDS is your T cell count. Wernicke's encephalopathy. Wernicke-Korsakoff syndrome has to do with usually chronic alcoholism, thiamine deficiencies, caused by vitamin B1 deficiencies seen in alcoholics due to impaired absorption and storage of thiamine. Primary feature in Korsakoff psychosis, which is a progressive pattern of retrograde and anterograde amnesia with intellectual slowing and a flat affect. You guys, if you get drunk too much, too quickly, it's not good. I don't know if I had to tell you that or not, but don't. They'll have blackout over and over and over again, and this is going to cause, as you can imagine, problems in your brain. You guys, if you want to drink, go for it. If you want to drink and get blacked out, you know, you do you. But if you want to get blacked out every night, I hope you enjoyed your brain while you had it, because it's not going to be there much longer. Hepatic encephalopathy. This obviously has to do with the liver. Again, buildup of toxins in the bloodstream due to progressive hepatic disease. Encephalopathy may be triggered by infection, GI bleeding, metabolic derangement, or treatment focused on reversal of the causative agent, supportive care, and elimination of ammonia via lactulose. Takes a long time though. Finally, let's look at chronic traumatic encephalopathies. CTE, this is a big one. This is the one that's killing all of our football players. Well, not right now because there is no football. This is also a thing that's damaging to soldiers. People that have undergone IEDs, explosions, concussive events might have some CTE. The problem is if we're experiencing multiple concussive events or even subconcussive events, meaning that you don't get concussed from it, but you get your bell rung. That's what we used to say. This can cause that. Boxers, MMA fighters, football players, they're getting lots of near concussive events all the time. Have any of you guys ever had a concussion? Any of you guys ever been knocked unconscious for a little bit of time? You had a TBI? Was that due to something that happened in the service? Because those can be truly devastating. In the movies, we downplay them so much, right? In the movies, how easy it for you to just hit someone with the butt of your gun and then they get knocked out and they wake up a couple hours later and they're fine, maybe a little headache. Yeah, that's not how that works, right? It messes you up, and it'll mess you up for a long, long time. It was a parachute accident. My goodness, Phil, glad you're still with us, my man. Yeah. Did you notice? Here's the question. Did you notice any personality changes afterwards? Absolutely. What kind of personality changes would you say you noticed, Phil? I mean, is that when you started enjoying surfing more? No. Memory. Yeah. So that's a big one that will get affected. We're about to memory, anxiety. Yeah. Maybe even sometimes people notice that their temper gets a lot more erratic too, is a common one. Big time findings. Now, some people have had noted positive changes. I had a guy who was in a car accident. He came and he was in a car accident a few years back, and it completely changed his life for the better. He became like more of a type A personality. Before, he was very much an introvert. So sometimes we can see personality changes, not always in negative ways, but in sometimes positive ways too. The moral of the story is we don't really know how these things are going to affect our brain, but for the most part, they can affect our brains in negative ways. Phil, thank you for sharing that. I appreciate it. Hopefully you're feeling a little better now, although unfortunately some of those changes are just there to stay. But how long ago was that? Yeah, so over 10 years ago. It's pretty amazing. It's also amazing how well the brain can deal with these things ultimately. So we first started doing research into this. Well, we've noticed it for a long time. We used to call it being punch drunk, dementia pugilistica. Boxers would get this way. Dementia, memory loss, aggression, confusion, difficulties with balance and gait, depression, suicide, very high, which can appear years or even decades after the traumatic injury. In March 2013, researchers discovered an exome particle created by the brain shown to contain trace proteins indicating the presence of the disease. It can only be confirmed post-mortem, and this is the problem here. We cannot diagnose this while you're still alive. Most commonly found in athletes, football, hockey, professional wrestling, and other contact sports. Now, this kind of first came to the public's knowledge when Junior Seau killed himself. 2012, Junior Seau committed suicide with a GSW to the chest. In his suicide note, he left a lot of information saying that he thought that football had changed his brain and he wanted people to do research on it. That's why he shot himself in the chest, not the heart, or not the head. By the way, that's a way to go. My God, it probably took him a while to bleed out and suffer from that. It would not be as instantaneous as shooting yourself in the head. Ray Easterling commits suicide. CTE postmortem. Junior Seau, CTE postmortem. They did study his brain. He had it. Jovan Belcher killed his girlfriend, drove to Arrowhead Stadium, commits suicide. CTE. 4,000 former NFL players filed a suit. They settled for quite a few bucks, but not that much considering that their brains are now altered forever. Here's the problem with this. 91 former NFL players have died and had their brains autopsied post-mortem. 96% of them had CTE, 87 out of 91. So unless you're a kicker, you're probably going to get it. Everyone in the NFL, unfortunately. Now, the problem isn't necessarily with NFL players who have millions of dollars and millions of adoring fans to look after them. The problem is with soldiers that are experiencing these and are not receiving their care at the VA, because I think we all know that the VA could probably use a little TLC. That's chronic traumatic encephalopathy. That's a big one. Careful for it. Most of them are mild. 80% of all veterans display persistent symptoms more than 6 months post-injury. Most of the TBIs are blast wave exposure. Occasionally, you'll get someone who parachuted upside down. The incidence of these injuries is understudied and underdeveloped due to concurrent injuries from the blast requiring greater attention. In other words, someone who's been blown up, we're obviously more concerned about all the other injuries that they're facing, not so much their mentation. But we need to be concerned about their brain going forward, which, like I was saying, probably one of the more fascinating sections that we go over. I think that the brain is incredibly amazing and complex. I really wish that I could do more research on it. The problem, like I was saying the other day, is that we really don't have a whole lot of research on this. It's very hard to research the brain. We have more technology now than we've ever had before, but it's still very difficult because everyone's brain reacts differently. I was talking yesterday about how so many calls that we run on in EMS and 911 are behavioral in nature, or there's a behavioral component to it. And one thing that I've really noticed from doing just thousands and thousands of assessments over the years is that I try not to let it color my assessment, but it definitely needs to play a role in my understanding of the assessment. For example, we're talking about medications. I don't know every single antipsychotic medication. I don't know every medication for schizophrenia, every medication for bipolar, every medication for manic depressives, whatever. What I do know is there's quite a few common ones. For example, Seroquel. Seroquel is a very common one given to people with schizophrenia. A lot of times you might not necessarily find a patient on Seroquel, but when you're asking about any drug allergies they might have, they might say, oh, Risperdal or Seroquel, or there's a handful of other very commonly utilized antipsychotics. That should definitely play a part in your assessment. Now, again, like I said, just because someone has a history of mental illness does not mean that that's what's going on with them right now. But it absolutely does play a role in your understanding of how that patient functions as a healthy human being. So without going too much more into that, let's talk about some neurological disorders, not necessarily mental disorders, because we need to separate those two things. Just because someone has a problem with their brain function does not mean that they have a problem with their behavioral status. All of this is affected by various portions of the brain. Most behavioral things are going to be located in the frontal lobe. Remember, that's where our personality, our behavior, at least that's where our understanding of personality and behavior and the reward cycle all takes place. These cranial nerve disorders that we're about to talk about here, they're not technically part of the central nervous system. They're part of the peripheral nervous system. These are the cranial nerves that branch out of your brain in the cervical spine, and they innervate a lot of important things. I believe we have 12 cranial nerves. Some of the more famous ones you guys know about are probably the vagus nerve, the facial nerve. Those are probably the big ones. There's a lot of them that have to do with swallowing, with sight, with taste and hearing, a lot of our senses, basically the way that our brain takes in outside information in order to perceive the world around it. So let's think for a second before we get started about consciousness, because that's kind of an interesting concept. What exactly is consciousness? We don't really know. Philosophers have spent basically all of human history trying to define consciousness and what it does for us, why we even have it. What's the purpose of consciousness? Most cells don't have any sort of consciousness. In fact, again, going back to those very first cells, even the ones that eventually became the cells in the mitochondria, they're floating around in the water or in the environment somewhere. And they don't have any sense of perceiving the world around them. They just do two things. When there's no food around, they speed up. When there is food around, they slow down. You could say that this is a form of consciousness. It's a form of reacting to their environment, but it's kind of just an instinctual reaction. Then we had creatures that could look for certain types of foods. And in order to do that, we have to have some way of understanding the environment around us. Either we have to have some sort of chemosensors or barosensors or something that can detect changes or movement or anything like that so that we can go towards that thing and consume it. And by we, I'm talking about single-celled organisms. And eventually things got more complex, and then it discovered that it preferred certain things and it did not prefer other things. So now it has to be able to differentiate between those things. So now further sensors are going in place that can smell or sense certain chemicals or certain foods that it wants to ingest and certain things that it wants to avoid, or maybe even things that want to eat it. And that was the next leap in consciousness. Then we started getting more complex ways of interacting with the environment around us, namely the eyeball. And we're going to go over the eyeball later. It's probably one of the most fascinating things that we developed. And we developed two of them because we have something very unique called binocular vision. Well, and we'll talk about all that when we're going over the special senses a little bit later today. Finally, we have to be able to not only see the environment around us, but also to interact with it. So you're some sort of primeval creature crawling around on the land, and you're looking for things to eat. And now you have to have an understanding of, I found things to eat in this area yesterday. Today, I will go back to that area. So now you're understanding this concept of object permanence. And when we look at little kids develop this at about 8 months old, right? If you've ever spent time with a very young baby, you can play peekaboo with it. You can play peekaboo with that baby all day long until you get tired of it, or the baby gets tired of it, or something happens. One of you two cracks yourself. Babies don't understand that when something leaves their field of view, it still exists, right? As far as they're concerned, if they can't see it, it must not exist anymore. When mom walks around the corner, mom has just disappeared. Mom is never coming back. They're kind of like very simplistic animals. But even animals develop that sense of object permanence almost immediately. Chickens, stupid chickens. A chicken lived for years with its head cut off. Chickens understand object permanence the day they are born. So really, we're very lucky as humans that we're very cute as babies. So that's why we feel compelled to take care of each other. This is all part of biology, right? The whole function of human evolution is to pass on our genetic makeup and continue our genealogic lines. DNA wants to survive. The rest of it is just kind of happenstance. Now, these cranial nerves are pretty amazing. They're very complex. There's a couple of them that can cause problems for us in EMS, and we're going to talk about those right now. Some of these are called hemifacial spasms, trigeminal neuralgia, and Bell's palsy. And don't worry if those sound very complex. We're going to go over them, and they're going to make a lot more sense. So the first one is called hemifacial spasms. As you can guess, these are facial spasms on one side or the other. Unilateral synchronous spasms of facial muscles due to dysfunction of the seventh cranial nerve, the facial nerve, possibly caused by compression of the facial nerve by a blood vessel. Sometimes tumors can grow, sometimes an aneurysm can form, something like that, which will press or narrow those cranial nerves. We call this stenosis. Anytime a lumen or a passageway is narrowed, it's called stenosis. It's almost like kinking off a pipe. So we treat this with Botox injections. Later on, we discovered Botox, also a form of botulism, can also be used to help pull back these cranial facial nerves in order to give you a more youthful appearance. So again, everything will eventually turn to vanity, but it does have its roots in medical practice. Kind of the same thing as Viagra, Cialis, all those erectile dysfunction pills. We didn't develop pills because we wanted to give old guys better boners. We developed pills because we wanted to end pulmonary hypertension. That's what those drugs were designed for. And by the way, they work really well for it. But they also have this interesting side effect that we actually enjoy a lot more. We have a lot better drugs for pulmonary hypertension. The most common one is called sildenafil. And I'll go over that. Actually, I don't think I'll go over that later. That doesn't matter. So, second one is called trigeminal neuralgia. And this is also has another name, tic Dillereau. I don't know if that's any easier for you to remember. Trigeminal neuralgia is not that bad. It's chronic pain condition that affects the fifth cranial nerve, the trigeminal nerve. That's where it gets its name. One of the most widely distributed nerves in the head. Extreme sporadic bursts of intense, shocking pain, which can be physically and mentally incapacitating. Here's a show of where the trigeminal nerves innervate. They also innervate the jaw and the teeth. My grandma, before she died, she had a series of really terrible strokes. And it started off, before she had any of the strokes, it started off as she was having really bad tooth pain. She went to the dentist, she went to a specialist. There was nothing wrong with her teeth. The problem was in her trigeminal nerves. It was innervating these lower teeth and causing incredible jaw pain because a tumor was forming in her brain. We didn't find out about this until she started having strokes. And by then, it had developed kind of almost like a form of dementia or Alzheimer's. So I never really got to see my grandma again, but the last thing that happened to her before all of this was really bad tooth pain. So that's one of the ways this can manifest. All right. So tooth pain, you might not think of it as being a very serious medical emergency. And in most cases, it's not. In most cases, it literally is related to the tooth. But sometimes it can be related to these cranial nerves. Again, sometimes caused by blood pressure, some sort of pressure, stenosis of those nerves. It can also be caused by injury from trauma, dental work, or stroke as well. Excuse me. Bell's palsy. Now, Bell's palsy is going to be a very interesting one that might be important to you as an EMS provider because it looks like they're having a stroke. Now, most times when you get a patient and they have facial droop on one side or the other, and that's the only thing going wrong with them, you can ask them, do you have Bell's palsy? And most of the times they'll know. If they don't, this might be a new onset of Bell's palsy. So what is that? Again, the seventh cranial nerve, the facial nerve. This can occur when the nerve exits the skull and becomes irritated through any of the following disease processes. Basically, all of these diseases, most of them viruses, can cause problems with it. And again, remember how the old last one was unilateral facial spasms? The same thing, right? We have two of these nerves coming out, innervating each side of the face. So one side will usually be affected rather than both simultaneously. You can see that this is pretty widespread as well, but notice that it does not have very much going on in the eyebrows. This is going to be important for our assessment ability. Let me show you. So this is a type of paralysis affecting the facial muscles on one side. It can be temporary or permanent. Symptoms begin to abate about 2 weeks and complete recoveries within 3 to 6 months. 80% of all cases of facial paralysis are diagnosed as Bell's palsy. Here's an example. As you can see, This looks very similar to a stroke, right? We've got facial droop because we've got hemifacial paralysis. So how do you differentiate this from stroke symptoms? Well, there's a couple ways we can do it. For one, stroke, as you guys will remember, is a 3-part assessment. We're looking for facial droop, arm drift, and then any speech abnormalities. Now, obviously, if half of this person's mouth has been paralyzed, including part of their tongue, they might have some speech abnormality, some slurring of their speech, but they would not necessarily have any disabilities in getting their ideas out, right? As long as they're at their baseline. So one test that works really well for differentiating Bell's palsy from stroke is, remember, when we're doing our facial droop, I'll always tell my patients is, can you smile really wide for me? Show me all your teeth. And I'll give an example. And I smile at them. They smile back at me. If you smile, you'll feel showing all of your teeth, almost like you're gritting your teeth and like just trying to show off all your teeth. That uses a lot of muscles in your face. All right. If we've got facial droop, expect to see significant changes one side or the other. The second thing you can add on to that is smile at me with all your teeth, raise up your eyebrows as high as you can. That uses a lot of muscles up in your forehead, and that usually will be unaffected. So sometimes people with Bell's palsy, very frequently, they will have facial droop in their lower, their cheeks and their mouth and their face, but they will not necessarily have it in their eyebrows. And that's generally a good way of differentiating. Is it your job to differentiate those in the field? Not necessarily. Like I say, most patients that have Bell's palsy will know and they'll tell you about it. But it could be that it's a new onset of it if they have some sort of new acute tumor or something that's causing the disorder in this cranial nerve. Finally, Meniere's disease. It's not necessarily a cranial nerve disorder, but we need to mention it because it has a very interesting patient presentation. It's a disorder of the inner ear, the cochlea and the semicircular canals, that causes spontaneous episodes of incapacitating vertigo, fluctuating hearing loss, tinnitus, and pressure in the ear. We don't really know what causes Meniere's. It's caused by quite a few things. There is no cure for it, unfortunately. Abnormal amount of fluid in the inner ear. We call this the endolymph. Allergies, viral infection, head trauma, genetic predisposition, migraines, or abnormal immune response. Most of these patients will eventually have pretty significant hearing loss. And there's quite a few degenerative neurological disorders. Most of them we think about are Alzheimer's, dementia, those slow onset, permanent changes in brain chemistry and brain physicality. Alzheimer's is a primary dementia by cortical and hippocampal degeneration leading to neuronal loss. So your neurons are just degenerating. The brain is actually becoming smaller and atrophying when this is happening to you. Primary mechanism is the loss of neurotransmitters, especially acetylcholine. Remember that's a very important one for controlling parasympathetic nervous response. Slow onset, which leads to cognitive memory impairment. Patient's decline terminates in near total mental and physical debilitation. As you can see, advanced Alzheimer's will literally degenerate the brain. Parkinson's disease. Loss of dopamine secreting neurons. Remember, any dopamine is used for mood and it's also used for muscular movement. So anything affecting dopamine is going to affect muscle movement, which makes sense in Parkinson's. Function, it leads to tremors, muscle rigidity, difficulty walking, and then stiff-legged or tiptoe gait. And multiple sclerosis, MS. This is a disease where our body, an autoimmune disease where our body starts attacking its own neurons, specifically those myelin sheaths which surround the neurons. What is the point of the myelin sheaths? Well, the cells that make up your neurons, like all cells, have the same things in them, right? They have mitochondria, they have nucleus, they have all those little organelles inside, but they have a different shape. Neurons are very, very long. Very long. So when they need to send a message to something else, they shoot electromagnetism all the way down those neuronal bodies. They do this the same way all cells do by reaching an action potential, and then boom, it fires and it goes and it releases something at the end, and then it affects a new one. These are long, long neurons. So in order for them to effectively shoot electricity, we need insulation, just the same as if you're wiring a bunch of different wires next to each other. There's electricity passing. That electricity would jump from one wire to the other if we didn't have some way to keep that electricity kind of in the chute, in the tube. So that's what the myelin sheaths do, is they act to help speed up those neuronal impulses and also to make them more effective. So if our body starts attacking the insulation around the wiring within our CNS and peripheral nervous system, that's obviously going to cause big problems with our movement. Those signals are starting to start to get crossed, or they're not going to travel as effectively. And we see this very clearly in the inability for them to move with any sort of clear dexterity. We call that ataxia, which is the loss of specific movement. All right. Remember, I told you yesterday, opening your Reese's peanut butter cup? That's very difficult for someone with MS. MS also affects a lot of things in the brain, right? Because all of your special senses are controlled by neuronal changes as well. So we're going to see a little bit later some of the problems associated with that. And then there's ALS, Lou Gehrig's disease. We don't know what causes this. It's not known in 90 to 95% of cases. Sometimes there's a genetic disposition, but again, quite a few cases with no evidence of that at all. This is a very quick acting disease. Average occurrence of the disease to the occurrence of death is about 3 to 5 years. Unfortunately, we do not have a cure for ALS. We're working on it. Stephen Hawking had ALS, for example. He was alive a lot longer than 3 to 5 years, as you guys will recall. He died, I think, last year, sometime like that. Maybe it was 2 years ago. But he lived with ALS for, I think, 15 or 20 years, quite a long time. Of course, he was also getting the best medical care available. Finally, there's Guillain-Barré, again, another autoimmune disorder, inflammatory destruction of myelin surrounding the spinal cord nerve roots, similar to MS. So they'll have symmetrical motor weakness that starts with tingling in the feet and progresses up to the head. They'll become locked in, and eventually they won't be able to move anything except for their eyes, almost like they are paralyzed. However, they can recover from this sometimes. And myasthenia gravis, another autoimmune neuromuscular disease caused by a defect in transmission of nerve impulses from muscles due to the blocking, alteration, or destruction of acetylcholine. Remember, that's for the parasympathetic nervous system. This can be helped with medications. And finally, I believe this last one, cerebral palsy. A lot of disorders affect cerebral palsy. It's not caused by muscle or nerve involvement, but abnormalities in the brain. So the neurons are fine. The problem is in their connection points in the brain. That's where the blocking is happening. Kind of the same way that when you take a pain pill, you're still feeling all of that pain, but your brain is just ignoring it. It's just not accepting the chemical transmissions that would make you feel the pain. All right, and here's the last one, lupus. Lupus, we're going to go over again in the immunology section. Lupus primarily affects women. Just like HIV primarily affects men, lupus is the #1 most common autoimmune disease that women can face. In fact, I think 80 to 90% of all lupus cases are women. Again, it's a very devastating autoimmune disorder, so our body is attacking its own cells. And we're going to talk more about that in the immunology section. All right. Finally, we're just going to go over this very briefly. The spinal cord can become compressed, and depending on where it can be compressed, we might see various different things. Acute compression would be if it happens really quickly. This would be like a really rapidly developing abscess or something like that. Subacute would take a few days to weeks. It could be tumors, hematoma, herniated discs, subdural epidermal abscesses. And then there's chronic, which would take months or years. Spinal stenosis, remember, narrowing of that lumen. AV malformations, the same thing in your brain also happens in your spine. Extramedullary tumors, so tumors outside of it. All these things would cause stenosis in one way or the other, pressing on things, causing blockages, narrowing the transmission of nerve impulses. I had a really great chiropractor, and he was able to demonstrate kind of a fascinating thing to me. So I went in, and I've had some neck pain for a while, and he laid me down on the table thing, and he had me do this thing where he was like he put his hand on my foot and he told me just to like raise my right leg up, and I did, no problem. He said, all right, raise your left leg up. I did, no problem. He said, all right, now I want you to turn your head to the left. I turned my head to the left, and he said, all right, now put his hands on my feet again. Raise your right foot. I did. He said, raise your left foot, and I could not raise it. It wasn't like some sort of parlor trick or like, you know, bar trick or something where he was like holding it more solidly down. Literally was the same amount of pressure, but just from turning my head to the side, I was causing enough stenosis to limit the input that was going down my efferent nerves and would have affected my muscles. We call those motor neurons. Remember, there's two types of neurons, motor neurons and sensory neurons, also known as afferent with an A and efferent with an E. Afferent goes towards the brain. Those are the sensory neurons. It makes sense. You sense something, and then your brain interprets it. Then your brain sends out motor neurons to move, all right? Efferent. So those efferent passageways, the strength can be lessened by about 60% if just from a slight stenosis. So literally, just from turning your head to the side, when you have these problems, like a herniated disc or some slip disc or something like that, it can cause pretty significant weakness one side or the other. After he cracked my neck, he did the same test to me. Looked to the right. Both legs were fine. Looked to the left. And then again, I was able to raise my leg up. One of the stranger things I've experienced, but that's why I recommend getting a really good chiropractor that knows their stuff and they can show you these things. It's definitely an art. All right. Finally, repetitive motion disorders. I believe this is the last one. They're a family of muscular conditions that result from repeated motions performed over the course of normal work. Think of carpal tunnel syndrome. For example, I was a trucker for 2 years. When you're driving a truck, you're using the clutch a lot. You're also switching your right foot from the brake to the gas, brake to the gas, brake to the gas all day long. Now, realistically, those semis, you don't need to really even use the clutch. You can float those gears just fine. But I still notice differences in my right to left foot. There's differences in the musculature of both feet. And I'm sure many of you guys will notice this just from driving around. All my toes can crack on one foot and none of my toes crack on the other foot. These are just really strange little kinks that are different just because of these repetitive motion disorders. For example, I'm sure you guys have gotten a massage before. A really amazing thing that good masseuses will notice is right away whether you are right or left-handed. They can tell that almost instantly. And the way is because we have different musculature in our right and left forearms. It might not be so noticeable when you just hold them out and look at them, but to someone who spends all day thinking about how muscles connect and how muscles form and how muscles get worked, masseuses, good ones at least, will notice that almost instantaneously. Very interesting.